First of all, thank you for the invitation to talk about this topic, which is certainly not my prime area, but it's quite interesting because we are now coming into a time where living with chronic disease becomes everyday life for the next generations of elderly people, which is exploding in the industrialized world. I have some take-home messages, which I'm not quite sure the right ones, but it's at least some ones, and that's about, for the first take-home message is the fact that the prevalence and the incidence of both these diseases are increasing. The other one is that we are interested in my area of research to find out if we could predict who among the cancer survivors would be later diagnosed with a diabetic disease, because we would be interested in finding out how we could prevent that event to occur. Is this solely a matter of the treatment, the rough treatment that we give to the patients? Is it the lifestyle changes initiated by this toxic treatment? Or is it more a combination of genetic and phenotypic characteristics of the patient? The project that I'm going to show you just one slide from is a discussion, arise from a discussion about whether it would be possible to determine pre-cancer metabolic status and then use that as a predictor for subsequent risk for cancer and the subsequent risk for late effects. So imagine that you have access to biological information about an individual years before the person is diagnosed with cancer. Would it then be possible that there would be organ dysfunction or organ interplay that was not normal, which could predict that this patient or this person is at a higher risk for becoming a cancer patient? I also have an underlying or overlying issue, which is about how we do the workout and follow-up of citizens that are diagnosed with chronic disease. And I think we have to discuss or relate to or do research within the area of integrating the various specialties we have and do not continue to serve the citizens in silos where the patient is running around from one outpatient clinic to the other and the GP to live a normal life with the 2-3 diseases you have as an elderly citizen. I have a conflict of interest to declare, that is that I don't know almost nothing about diabetes besides what I learned in medical school. I only worked 4 years as a real doctor and then 30 years in cancer research. I got my 2 Pfizer shots 3 weeks ago, my second shot at the hospital. And most of my research is in the survivors. So I'm not I have done about maybe 50 papers in etiology, but my major interest has been about survivors, both using clinical studies, epidemiology, and RCTs in behavioral interventions. This is, by the way, a doctor that hadn't been using a needle for 3 years and asked the nurse, how is it I do when I start up? Very interesting when you're waiting for your first shot. It's probably well known in the audience that, but I'm not so keen in the topic, so I had to read some texts to find out, but that you increase your mortality. And it's especially if you have a diabetes diagnosed close to the cancer diagnosis. That touches about on the topic whether diabetes is an entity different from the cancer, or if the diabetes could be looked upon as a signal disease prior to the cancer. You could say that the entities that are available in ICD-10 is building on some, you could call it philosophical or etiology considerations about what a disease is, which differ this particular disease from another disease. And I think this is maybe questioned, especially because this finding that diabetes very close to the cancer diagnosis seems to be dangerous. It's mostly those patients treated with insulin that are at a higher risk, and the risk decrease as you go down the line to treatments for type 2 diabetes, and to those patients that can manage and cope with the disease by dietary changes only. The international societies for cancer treatment, my small world, is ASCO or ESMO, the international and the European associations, do not have guidelines which point out how you're going to treat a patient who at the same time, when living with a cancer disease, has chronic disease. In a study of about 250,000 incident cancer patients over a 10-year time period, we identified all cancer patients in Denmark, which has a population of 5.6 million. And these about I think it's about 250,000 patients. We observed that every second cancer patient at the time of diagnosis has at least one other chronic disease, and every third fulfill the criteria for having polypharmacy, which is that you are taking 4 different drugs daily. It's just to show you that the population of diseases, in this case cancer, is not de novo ill, but are people that already live in a situation where their biological organism, their organs, the interplay between organs, are influenced by difficulties in the biological system and are treated with drugs that we do know will have side effects that could influence both the disease they had when diagnosed with cancer and the success of the cancer treatment. In a new paper we just have submitted, we show that these patients having chronic disease, when they are diagnosed with cancer, have a highly significant worse mortality or survival, worse survival than patients are not being characterized by either multimorbidity or polypharmacy. So it's extremely dangerous to have these conditions. And when we at the same time know that every second cancer patient is in this situation, I think it calls for guidelines, and it calls for considerations about how we could standardize and protocol the treatment of such patients. You could now have a couple of slides showing how all drugs are developed on patients that are de novo cancer patients, well fit, and so on. You know that problem probably. Here show you a slide from the paper that we recently published, and what I want to point out is, I hope you can see my arrow, but in the y-axis line you can see that diabetes is number 5 here, and out here you can see the percent with comorbidity. So we are talking in this row here about 0, 10 to 20, 30%. And you see, for example, that diabetes is prevalent in pancreatic cancer, liver cancer, but also in all the other cancers. It's around 10% of the patients here, bladder, kidney, and so on, that have diabetes at date of diagnosis. Here's a little lower: ovarian, malignant melanoma, brain, and rise again to non-Hodgkin lymphoma, leukemia. Just to illustrate that, and if you look across this bubble plot, you can see how the conditions are, so to speak, equally distributed across the pattern, and how, for example, how many patients have had a stroke, but also looking how how prevalent depression and anxiety is among cancer patients when diagnosed. So already at the start of the diagnosis, they are in a different condition compared to the population. At the same time, the diseases do share risk factors like smoking and obesity. And we also know that lifestyle changes can improve the outcome for both diabetes and cancer. In diabetes, it's clearly indicated and it's well known, and patients are forced to change their diet. And although we have quite good evidence from a number of observational prospective cohort studies and even a number of RCTs, that changes of the lifestyle in cancer patients may improve their outcome. We do not have recommendations internationally or nationally for changing the way patients live when diagnosed with cancer. So there's no standardized, what can you call that, recommendations from the National Board of Health about physical activity, change of smoking behaviors, alcohol consumption, or dietary recommendations. Second to that, we also know that social factors play a role in survival of both diseases. We do not talk so much about it, but for example, in cancer, it's probably the most important factor after stage. In a paper in JAMA Oncology, we looked at the long-term somatic disease risk in adult cancer survivors. And I just wanted to show you here that, just one slide from that, for example, if you look at breast cancer, and you look at the diseases you can be submitted for in the hospital system, you see that endocrine system diseases, which include, of course, diabetes, we have up to 30% significant increased risk for lung cancer. We have something like 2.24 down here for prostate cancer. We have 1.17 for colon. It's about 1.42. Just to illustrate that following a cancer disease, in the years to come after the treatment, there will be probably a higher risk for being hospitalized with diabetes compared to the background population. So one research question is, would it be possible to identify persons early on, I mean, even before you have those subjective symptoms, which leads you to visit the GP to find out if you have something which is not right? And so that's a precursor. Could you identify a precursor, so to speak? And the second research question could be if changes in these metabolic markers before cancer also could be markers for metabolic endocrine diseases following the cancer treatment, a late effect that I'm currently interested in. So which changes in the metabolism before cancer were maybe a predictor of a later problem? We actually looked at a study we published last couple of years ago in a cohort of Danish lymphoma survivors, where we showed that those patients having cardiovascular disease at the time of diagnosis of their lymphoma had a higher risk following the treatment for cardiovascular disease, increased severity of their cardiovascular disease. So that illustrates how an existing disease may develop when systematically treated for cancer disease. So my third question would be, if we are in a situation that procedures which would address such questions, which I think is highly interesting, actually in a situation where we could do this in the clinic. So today, if we look at the so-called cancer sequential trajectory, the first arrow points to the fact that all patients undergo standardized workup. And if you look at the blood sample program, it's extremely limited. I think it's about 2 to 3 tests we take before they're put on chemotherapy. If they're going to be operated, anesthesia will look at the patient and they will take few cardiovascular indicators of function, but there's no, what could we call it, thoroughly programmed testing the function of major organs. When treatment is finished, we put patients into a follow-up program, which depends on stage, and we have no defined protocol for patients having different comorbidities, and by the way, no protocol that assign resources to patients in more difficult social situations compared to those that are more well off. And then patients are put on a passive waiting position, and there's no structured activation of the patient or relatives. There's no integration with other follow-ups from cardiovascular disease. It could be hypertension, diabetes, some problems in the joints. Your eyes get old, you cannot hear so well, and all these things are running in parallel. And the post-treatment activities could be rehab, and treatment of late effects, for example, could take place. So right now, all patients are seen by a doctor and a nurse, and prescription referrals are only by doctors. This means that that has a long history why that is the case, but in other countries we are operating on a much more free assignment of the responsibility under the guidance of a doctor, and that could be changed more thoroughly here, I think. And we follow up all these patients in different clinics, and it's extremely expensive. And you can say that now it's a contrafactual activity we carry out. We talk about personalized medicine, but all we do is to disintegrate the person in the name of the specialties that we as doctors have created, which of course have their historical reasons, but we are not using the evidence we have today to integrate the follow-up. So what I say here is come for the first point. I think we need to regroup and use the evidence we have to organize the health system and use this data as our compass needle in future. But of course, we need more data to convince the clinicians that these changes are needed. Ongoing, we have a project which is the COPLab project, and that is this idea. The reason why I'm a little bit reluctant to share anything is that we are just opening up a huge database where we have information about biomarkers, and we are interested in finding out whether these biomarkers may predict late effects in cancer survivors. So the database has the response from 176 million blood samples. And this is the only lab in a 15-year period in the capital region that was assigned to test or to analyze, blood samples from the GPs. And the population is about 1.4 million people. And in the 176 million blood samples, besides those samples and the response to that, the level of values, we have also close to 200,000 EEGs. We have respiratory testings. We have a so-called feeling tired package where patients are being worked out for anemia or whatever. And we have a lot of other interesting data, which I think we will be using also in the time to come. And I'm not sure whether there are any international people listening now, but so just a short note that we have history of national population-based numbers, so to speak, of health and disease. And that means that we have up to 50 years of almost complete data in the population due to the tax-paid public health system with free access on all levels. And the key operator is a personal identification number that was assigned to all citizens or even residents since 1968. And that has been continuously updated on a daily basis. So when you die, you're only alive 5 more days, and then you will be deleted in the registry, or you will be put on the other side of the border. You're now dead. So it's a very effective follow-up of all citizens, much more effective than you can imagine when it comes to admissions to hospitals for both somatic and psychiatric disease, but also for the use of GPs and so on. So in this COPLab database, we are now configuring it, and you probably know how it is to take administrative data and change it into something useful for research. But we defined a cancer population in the COPLab database, and that was about some 75,000 people that had their first cancer in that time period. We are not yet going to the case where we are adjusting for prevalent diabetes or other chronic diseases. And I say this because the diagram I'm going to show you looks interesting, but there are probably limitations in it. And we found about 15,000 cases of digestive cancers, just as an example. And what I show you here is every color is a blood. This is leukocytes. This is thyrotropin, for example, bilirubin, and so on, CRP. And this line is the baseline. This is the normal level, 0. And this is 1 year before diagnosis. You can see the relatively high activity. The blue one is something about glucose. So if you look at these light blue ones, it's glucose. And if you look at that 2 years before diagnosis, there's still more activity. 3 years, still more activity. 4 years, and so on. You can see, of course, 6 years before, the level of activity is not that much higher, but still higher in a person who is later diagnosed. That would mean here, for example, who is later diagnosed with a cancer in the digestive organs. And if you imagine that you make a line here using this activity, it will have some kind of like high steep increase here the last 2 years. There's something here 3 years before, but it just points to the fact that we actually can see for some values that are a little bit, maybe the doctor is trial and error searching for something which could explain why the patient, if this is true, comes to the doctor with some uncertain, unspecified symptoms. That is not completely straightforward to interpret and assign these symptoms to a cancer disease, but they are not normal. And as you see, the values, I'm not showing you here the values. I'm only showing you the fact that a blood sample has been taken. Next step is to look at the values, but this is just the activity. But just to show you the pattern of activity before a cancer diagnosis is, in my mind, extremely interesting, because this could be signs of cancer that we should be more aware of than we have been. And I have to say there are really limitations in this. It's a first plot we have done, and it's a working paper, working document, and it's by no means ready for presentation as I use it today. But it just shows how desperate I was, because I don't know that much about diabetes. So you could discuss these observations and say, is it so that we actually have an increased GP contact behavior or hospital/specialist behavior before a cancer diagnosis? That could be interesting to look at. And the strategy of a GP's blood sampling choices could be an area of intervention by screening it with some artificial intelligence algorithms, sorry, where we could show variations which could be associated with a upcoming cancer diagnosis or another outcome. This could also go for diabetes or for another chronic or even maybe acute disease. So it just shows that maybe we have in the time before diagnosis patterns of behavior and changes in the metabolism of the entire organism or specific organs associated with the cancer that could be markers of that something is going on, and these patients should be looked at in a more thorough way. And I just note here that we haven't looked at the second side of the line, which is whether there's a pattern of blood sampling behavior which is specific to a later diagnosis of diabetes in the cancer population we have here. It's only 75,000 people or cancer patients, so the group is not that large, but we have quite well documented the behavior in a 15-year time period. So that's the strength of the upcoming study. So Some cancer survivors are diagnosed with diabetes, and we could talk about how we predict who becomes diabetic. That's one question. There might be an association between what we see long time before the cancer diagnosis. Do you see any possibilities in utilizing this information? And then this discussion about what I show you here is the glucose, which is not a standard measure when you do the primary workout of a cancer patient. So I think it illustrates what I was illustrating with my comment about the very limited workout before cancer treatment. It's just that in my mind, there's too little openness for a more heterogeneous examination of the function of the entire body before we start treatment, and that's a pity because it's not in the favor of the patient, and there could be some suggestions about how we do that. Yes, I think that was my 30 minutes. Yes, thank you. Should I stop my sharing now?
Yes. Yes, please.
Yeah, I do that. Okay.
Thank you so much, Christoffer, for this very interesting talk. It was very, very exciting. I can't see any questions in the chat for now, so I can ask. Sorry, did you say anything?
Yes.
Yet?
Could we take the poll? So we'd really like to know what you think about this webinar and the format.
Oh, yeah.
So while you are thinking about questions, you could please fill out the 2 questions that you see on the screen right now.
Wow. Okay.
Okay, and you're of course welcome to post your questions.
Yes. And I can start maybe, Christoffer. Very exciting and very interesting that so many patients have diabetes when they're diagnosed with cancer. That's really interesting, as you say, that all the studies in cancer treatments and in cancer patients are done in healthy people or people who are not diagnosed with anything else before their cancer. So that's really an interesting point. But I was thinking that do you think that diabetes patients would in your data material you said that the patients have a lot of contacts to GPs before they are diagnosed with their cancer? Is that different in diabetes patients? Do they have a different pattern when they go to their GPs? And do you think we could you were kind of touching upon it, but could we be doing better detection in diabetes, especially this population, in order to try to avoid to detect cancer?
You can say that diabetic patients is probably the most surveilled population of patients because they have many of them have daily blood sugar tests themselves. And when they're seen by their GP or the specialist clinic, they will potentially be able to report symptoms. So the diabetes pre-existing before cancer will heavily confound the finding of diabetes after. I mean, there's also some, so just you can say it's a little bit difficult. That was my limitation, is that I haven't adjusted for the existence of diabetes in this plot I showed you. But the increase in testing for me, generally across organs, for me showed the increasing activity still was of interest. But we are not able to say something really wise about your question whether they would have a different workout needed, but I think they would.
Yeah, I'd imagine. Yeah. Okay, it's going to be interesting to see. And we have a question from. Hope I pronounced the name right. Hong Li, who's writing, thanks for the talk. Can you comment on cancer cachexia, which is a link between cancer and metabolic dysfunction? Do cancer cachexia patients develop diabetes?
cachexia is the ultimate breakdown of the loss of muscle mass, and the entire organism is in a catastrophe mode, so to speak. I'm not aware of studies like ours where you have these long-term observation of patients where you look at to what extent cachexia could be prevented. But I know from several ongoing studies that maybe Bente will also talk about, that exercise and diet changes are the best interventions to avoid the catastrophic experiences of what do you say, of cachexia.